Assalamu alaikum. So now we are doing the procedure for vesicovaginal fistula. This is the findings of the cystoscopy of a 45 years old lady who underwent abdominal hysterectomy around 3 months back. So you saw the fistula. So we will pass a guide wire. This is the vagina. It is easy to pass guide wire from the vaginal side into the bladder rather than from the bladder into the vagina. And then we will pull this, grab this guide wire and pull it out through the urethra. Here you can see this is the guide wire. So we will grab it with a forceps and pull it through the urethra, and through this we will pass a ureteric catheter. This is for identification of the fistula site during laparoscopic surgery. So here now we have placed the ports. This is vagina, the vault of the vagina or the cervix. You can see the ovaries. There is also, you can see the bladder. So we are using a monopolar diathermy here instead of the sophisticated instruments, because the sophisticated instrument cannot actually cut the bladder without causing ischemia, and the ischemia of the edges of the bladder wall is not really what we want, because healing is always dependent on non-ischemic edges which are healthy and which are cut cleanly. We started a bit lower, however we felt that we must go a little higher. So we started opening the bladder a little higher than we actually planned, so as not to open the vaginal wall. You can make a lot of openings in the bladder, but such openings in the vaginal vault or the wall of the vagina are not recommended, because healing of the bladder tissue is much better than the healing of the vaginal tissue. So you can see here the ureteric catheter coming out through the vagina, through the fistula into the bladder. Now we put in and place 2 more ports. One is the left iliac fossa, one is the right iliac fossa. One is for the assistance as well as suction, and this will later on be used. This port of this suction will later on be used for suturing the urinary bladder in horizontal fashion, like we opened it. So there are 2 kinds of opening in the bladder now. One is transverse or horizontal opening, and now this is opening in the midline. So it is a T, in the shape of T, the opening in the bladder. We are cutting the edges of the fistula. Refreshing the edges of the fistula from the bladder side is important. It is not really important to refresh the edges of the vaginal wall. So a T is formed, and then in the closure it will be closed in the form of T again. So the port that we placed in the right iliac fossa now is used for retraction, used for suction and irrigation, and when we are done with the closure of the vagina and the T portion, of the bladder, we will be using that port for horizontal or transverse closure of the bladder opening, and this will make it quick and easy. Here we are separating the walls of the bladder and the vagina, taking care of the left ureteric orifice and left ureter, because on cystoscopy we saw that fistula is quite away from the right ureteric orifice, but it is a little closer to the left ureteric orifice. Here we have sighted the fistula, so we are trying to cut the tissue around the fistula, dissecting and making plane between the bladder and the vaginal wall. The more we mobilize, the easier it would be to close the two walls separately. So this patient remained incontinent for good 3 months. So now we cut the ureteric catheter so that the rest of the dissection is easy for us. We don't need it any further because the purpose has already been served. It made us identify the fistula. A little bit of cleaning, so a little more separation of the two organs is needed in the avascular plane. Separation or the dissection is good laterally, but at the apex there is still some tissue. And the other important thing is that we will put and place some fat, either omentum or epiploiky of the sigmoid colon, if it is reaching easily. The basic principles are the same. We need good vascularity, watertight closure, dual drainage by perurethral catheter. Here we have also decided that we will place a suprapubic catheter as well, because at times there is some hematuria and small clots can form. So if the catheter is blocked by small clots, all the anastomosis and repair would be at risk. So it is always good to place a suprapubic catheter, whether vaginal repair or open repair. And talking of the principles, we discussed the drainage. However, the two suture lines must not oppose each other. Since we have decided to repair the vaginal opening in the same line as the bladder repair, we must put in something in between the two organs, in between the two suture lines. So the mobilization is now almost complete, and we can have a good repair. So a 2-0 vicral suture, starting at a point which is away from us. Never start the repair near to you, because that would mean as the suturing progresses, it will be progressing away from you. So the last stitch will be extremely difficult to take. Suturing in a laparoscopy is not as easy as it would be in the open procedure. However, the retraction is not needed. You can go into deep cavity into the pelvis. We don't have the robot, otherwise robot has the advantages of both the two. You can have the freedom of movement of your instruments, especially the needle holders, the angle that the needle would go into the tissue, and as well as you can go into deep cavities like a pelvis. Care must be taken here as there is a vaginal pack placed. This is always placed in the vagina during a VVF repair laparoscopically, so that gas does not leak out. So care must be taken not to take the threads of this packing, because this will be extremely difficult then to remove the pack next day. So far as the catheter is concerned, we also need to clamp the catheter so that the gas does not leak through the catheter outside the body, because then the pressure will not be maintaining and procedure will become difficult. In the meanwhile, one can clean, irrigate with the assistant port that is additionally placed in the right iliac fossa. Right now, that suction tip is retracting the wall of the bladder for us. However, we have been regularly irrigating and cleaning with that suction. So this is the last stage, and the hole in the vaginal vault or in the interior vaginal wall is now completely closed. So we have to bring out the loop and then knot it. And before knotting, we will pull all the sutures so that the edges approximate and there is no chance of leakage through the vaginal wall. So the last stitch is now being taken here. Irrigation and suction will clean the field for us and to examine. So the hole is nicely closed. We are satisfied with it. And now bring out the loop so that it can be closed. It is always advisable to bring out the needle and bring it out under vision, because if the needle is lost in the abdominal cavity, it is difficult to find them. So follow it up till the port and then remove it. Now, talking of the interposition of the fat, we checked it. It is luckily quite long, the epiploiky of the sigmoid, and a stitch is taken in the apex of the repair of the vaginal wall where the rent was, and then it is brought there and fixed there. So it will be interposing between the bladder wall and the vaginal wall, number one. Number two, it will be completely covering the suture line in the vaginal wall. Here, nicely done. Can be done with a 3-0 suture, 2-0 suture, whichever you like. So it is then cut and is brought outside. And here you can see we have started with the bladder wall from outside in and then inside out. This is to bring the knot outside. However, nowadays they say that it is not routinely needed because it is an absorbable suture. So if the knot comes inside the bladder wall, it doesn't have any clinical significance. However, wherever you are able to do it, it's always better to follow the rules and the principles. Since we are in a teaching hospital, we have to teach our trainees with standard practices. And the standard practice is to bring the knot outside the urinary bladder. Now from outside in and now from inside out. Here one would feel that it was difficult to prick the vaginal wall because the vaginal wall is quite thicker as compared to the bladder wall. Bladder is quite delicate, so the needle can go in easily and come out easily. It is important to take the full thickness of the bladder wall because taking only the mucosa or half of the wall can be problematic. In the field, we can visualize the catheter bulb as well as ureteric orifice. We did not put in any stent. However, if there is any doubt, one can always place a ureteric catheter or a DJ stent in advance if there is any chance of or any danger of injuring the distal ureter if it is near. So you can see very clearly the ureteric orifice, and it is also pouring urine in the fashion of a ureteric jet. So we are quite satisfied that hopefully the ureter is not ligated or injured. Always pull the suture once you apply. We are using a vicryl 2-0 suture. It can be the repair can be performed with a vicryl 3-0 suture. Nowadays V-lock is also in fashion. The advantage with the V-lock is that it is actually a barbed wire, so once you pull it, it never loosens. So that is a big advantage. However, for the beginners, it is extremely irritating and difficult because it has got a very strong memory, and the handling of the suture is extremely difficult. So, and it is also very expensive. So we are using a suture which does not have memory. Yes, it does have, but not that much as the V-lock suture has. And it is cheap, and it is absorbable as well, and it doesn't break as well because V-lock suture is monofilament. So handling that suture with the needle holders or any other forceps can make breaks in the suture. So the portion of the fistula is now well repaired, as you can see. We are now coming to the bladder side, pulling it once again. So we leave this suture here and we use another suture through that suction port that I mentioned earlier. The ergonomics are very good, the angle is very good with this port, and in the suture that we use for the repair of the T is left there. So we will interlock with this suture when it comes to the half portion of the opening, and then we will continue this same suture towards the rest of the half. It is always good to have 4 knots in the vitral suture, because it has a propensity to swell up and it may get loose. A small bleeder in the bladder wall will be covered once the suture is tightened. This portion of the bladder repair is a little quick, because you can pull this thread. It will make the bladder wall nearer to you. The 2 lips of the bladder come together. You can do it in 1 layer, in 2 layers, whatever you like. So we are through the half of that rent. We are coming out now, and once we come out, we'll bring that suture in the loop of this suture. That previous suture is brought in its loop, so it will tighten that T segment as well, that T limb, and will tighten this one as well. And then the needle is cut, it is brought out under vision so that it doesn't drop in the peritoneal cavity and get lost. And then we knot this suture with the previous suture so that it is secure and doesn't get loose. And the water tightness, it remains in place. When the procedure is completed, we will fill the bladder and see if there is any leak. And this will also help us putting in and placing the suprapubic catheter percutaneously, and that too under vision. So far as the suprapubic catheter is concerned, it is not a standard practice. Usually the single periurethral catheter is sufficient. However, as I mentioned earlier, small clots can block the single catheter, and then it can jeopardize the reconstruction. So if one catheter is blocked, we hope that the other one would work. If the suprapubic is blocked, periurethral will be functioning. So if periurethral is blocked, then suprapubic will be functional. So the bladder rent is now completely closed in the manner in which it was opened. Now we will just knot it. In the end, we came to know that the suture length is a bit insufficient because we tied twice, once in the beginning and then in the middle. However, we are able to do the knotting around the needle. So the needle is cut again and brought under vision. Now a little bit of cleaning, suction, and see the fat stays in between the two structures, and then we clean all the area. We place the drain through that same port which was additionally placed for suction, for retraction, and then suturing, and now it is used for drainage as well. Now we fill the bladder, not overfill it, because overfilling may also jeopardize. You can see it is distending very nicely and there is no leak, no significant leak. Now the percutaneous suprapubic trocar, and through that trocar we place the catheter and then inflate the balloon. And so the procedure is completed now. Thank you very much.